All right. So first, without further ado, this is Dr. Tillotson's last QIC with us. As we were just talking about, she's leaving on Tuesday. We are trying to see if we can get her back to the country concert because she's expressed interest in that. So we're looking at some legal and behind the scene things to make sure everything's in the right spot. But hopefully we will get her back for that adventure. But that being said, I know it is a recognized holiday, but we wanted to make sure Kelly got this last QIC in. So I appreciate everybody's attentiveness and signing in for today.
The 75s have offered to sponsor Dr. Tillotson for the country concert if she needs a chaperone.
Yeah, there you go. There you go. And we will be final details are still getting placed, but we are getting another fellow that is confirmed. We believe we know which one. I'm not going to mention any of that yet until we have final steps in place. But it should be another good fit for us. So I'm really looking forward to that, although it won't be Kelly. So Kelly, take it away.
All right. Well, yep. Sadly, it's my last QIC, which I'm in denial over. I'm really gonna miss riding with everyone and spending time up here because it's been awesome. You guys have made my fellowship here fantastic. But in the interest of it being a holiday and to get through stuff, I did get to go through the cases for May and pulled out, I think, about 12 that I was going to quickly go through with one or two learning points from each of them, or just even some discussion points. So this was the first one that I got, was a 69-year-old gentleman found as a non-breather. Had a history of heart problems as well as diabetes, hypertension, typical stuff for Ohio. And when he was found,
and Missouri.
What?
And Missouri.
What about Missouri?
You said typical stuff for Ohio. We caught that.
Ohio's catching some shades in your last one out.
Anyway, so gentleman found unresponsive, had chest compressions being done. Interestingly, the first rhythm that they found on him was torsades when they put the paddles on. And ended up having to continue with resuscitative care for him. In addition, there was some discussion, I believe, in this gentleman, like they were able to get the Lucas on him, able to get IO access, gave him amiodarone, and then were able to get a 12 lead after they got Rosk on him, and ended up getting him to the hospital successfully alive. Overall, I think this one was well done. It was in accordance with most of the Southwest Ohio protocols. There was a couple things I wanted to talk on here first, because we don't run into torsades very often, which was the main thing I want to discuss. We will come back to this one in a little bit. So as a reminder, torsades is that polymorphic VTAC that looks like this, kind of undulating, getting smaller and then getting larger, getting smaller, larger electrical signal on the EKG. I looked into this because I actually wasn't 100% sure and have been asked this a couple times recently. But in the literature, when you're trying to manage torsades, if you see this and the patient is unstable, zap it ASAP with just defibrillation at standard defibrillation doses, which would be more high dose electricity. If they're stable, that's a situation where you can synchronize cardiovert them. So say someone who you see torsades up on the monitor, but they still have a pulse, they're still awake, they're still maintaining a blood pressure. That one you can take a moment to try to synchronize cardiovert. But if they're unstable, as in this gentleman, the sooner you get electricity on board for them, the better, as a defib. The other thing to remember for torsades is typically what ends up causing it is these patients end up having a super long QTC, which is the at the end of their QRS complex, so the end of the T wave. And then what ends up happening is because that repolarization phase or that reset phase is so long between the end of the QRS and the end of the T wave, they end up having another signal that comes on top of it and smacks into it, sending them off into this polymorphic VTAC. So the other objective, once you try to shock them back into a sinus rhythm, is to then button up that QTC interval. So for someone like this, based on Ohio protocol as well as some of the literature, probably the next step for them would be giving magnesium. You certainly can do amiodarone, but there is, I think in this case, having seen torsades on the monitor, this would be a scenario where it's reasonable to grab the 2 grams of mag that we carry and put that on as one of your early medications. Yes.
So I happen to be on this run.
Yeah,
The run of
glad you were.
the run of Torsat was very small,
Very small.
and then he kind of came out of Torsades.
Just Siri.
So
No one
you-
cares. Yeah, that's my Siri. No one cares.
I guess the thinking was if he's not currently in Torsades, do you still give magnesium, or if you just saw it once, do you give magnesium still?
I'll take Richard's thoughts on any of these as well, but I would probably still say give it. Cause they had enough setup to go into torsades once, there's probably still that underlying problem with their electrical signal, they could go back into it again.
Get it? Yeah.
So I would probably vote for still giving the mag, I think like, particularly since they went out of it, the amiodarone and they're in arrest at that point is reasonable, but I'd probably say still give it. What would your thoughts, Richards?
Yeah, I agree with that. For the reason the chance of going back into it, it still helps stabilize calcium channel membranes and these sort of things. And then I mean the side effect is pretty low impact. So if you've seen it once, even for a brief run, there's little harm unless it's taken up,
Okay.
the other stuff, I guess.
And then my second question is, what does it sync to?
They're gonna try to sync to whatever the main.
So it's just gonna try to grab one of those to sync it to?
Yep, so when they do it, that's what will happen. I had a case like this where he was stable, so we did synchronized cardioversion, and it will pick every single one of those large QRS complex deflections.
Okay.
And that's what it'll sync to. My caution with these would be realize that because it's, the machine's kind of like, well, this looks like a QRS complex, so that's what I'm gonna pick. Don't be surprised if the ends very quickly have to defibrillate them afterwards if you do end up causing an RNT, and that's just because of the nature of what this ends up looking like.
Right, okay.
But typically what the machine will try to sync to, you can see my cursor here, is they'll try to put a mark on each of these kind of QRS complexes. And then if that fails, they just have to go into, they'll degrade it to most likely defib, and then you just have to defibrillate them like normal.
Gotcha. Okay.
Yeah, great, thanks for bringing those points up. Because we don't see torsades a lot, like even in the ER, I see that way less than a lot of other arrhythmias, which is what I wanted to make sure we went over that. Which one was this one? I think this was the one that, let's see, I had a couple ones that were around arrest for this month. This case, that was a known gentleman who was dispatched for being unconscious, had a known history of heart problems. Patient was found to be not breathing, but still had a pulse. They then ended up degrading into arrest, at which point like pads were placed on him. This was one where there was a large amount of blood found in the patient's airway. And I thought the crew actually managed and documented this very well. They talked about like gentlemen's, of course, the top of the stairway because they could never collapse somewhere where it's convenient for us to take care of them. But ended up having 300 mils of blood in the oral pharynx or in the mouth that was removed. And they ended up successfully putting an eye gel in and establishing access, putting him on the Lucas, etc. And with the resuscitation efforts, they did actually get ROSC on him, which is great. Huzzah, we love to see it. I would wonder, having read this case over, if potentially given the amount of blood in the oral pharynx, if the gentleman either had potentially some GI bleed leading to that amount of blood inside of the mouth that's now refluxed up in the setting of an arrest. The other thing that could cause it would be like a tongue laceration if someone had some kind of myoclonic or muscle jerks as part of that initially going into cardiac arrest where you have all the muscle spasms. But I would almost wonder more towards the first one, something like the GI bleed. One of the things that was discussed though, and we see this quite a bit all over the place, is that after Ross, gentleman got collected up on the Reeves cot, brought out to the ambulance, and then of course rearrested. Did end up I believe we ended up getting him, this was the one that was pace, that's right. Put a 12 lead on, showed that he had AFib at a slow rate. And with this, they were not able to get a mechanical capture. We were on that, as we've talked about before, they were able to show pacer spikes going at causing a QRS complex to be created at a rate of 70, but not actually feeling a pulse with this. And it sounds like, based on the way this is written, and if anyone's on the run that wants to talk about it, please feel free to jump on and give more info or correct me on it. But based on the way that I read this as it was being written, was that they continued doing pacing, though this person still had a very slow pulse rate. And I've seen this a couple times when I've looked at cases where some of these post-ROS patients who end up being very bradycardic, or I've seen some, not necessarily here, but other times where patients are being paced because they're bradycardic and they're actually still in arrest. So there's two things I wanted to talk about in regards to this case. Number one, and this is going to be coming out in Southwest Ohio's protocol in the upcoming year, because I'm the one reviewing the protocol, so I can give you a brief preview on what's coming. There is a huge flux in the cardiac arrest care management from a national level to focus on trying to keep patients from rearresting, with the theory that once you get the heart beating, you have a lot easier time keeping them, easier in quotation marks, from rearresting, as opposed to trying to get them back after they have died a second time. They have found that kind of doing the stay and play model for about the first 10 minutes or so after ROS potentially can lead to people having better rates of ROS retention. There's some thought to why that is. Biggest one is that you can actually take a pause for a second and make sure that all of your equipment is set up to function well. So if your IO sucks because you've been using it for the last 15 minutes, maybe getting like an IV access at this point, or changing it to a different site that's going to be more amenable to transport. If your airway is tenuous, like maybe you need to quickly swap out your end tidal so you can monitor effectively. Put them on all of the monitors and try to get a set of vitals that you can see what you're dealing with. Put together a moving plan so that you can get the patient moved most efficiently without removing the equipment. Maybe setting the Lucas up so that it's where you want it, arm strapped in, all the other happy things. Biggest one that I have found going through the literature, as well as kind of through my own personal exposure to these in the ER and out of it, is that when these patients come back, they come back in a state of severe cardiogenic shock more times than not. And that'll present as patients having potentially severe pulmonary edema, where they've got all this frothy emesis coming out of their tube, and they're completely vasodilated, or they're just cold, not perfusing anywhere. In most of those cases, fluid bolus isn't going to help very much, or may potentially make it worse, particularly in the setting of pulmonary edema. So really the mainstay of therapy at that point is going to be some type of vasopressor.
So we end up meeting again.
Not yet. There's no talk about dopamine. There is talk though about, even on the national level, of making sure you've got, I would argue, a couple doses of push dose epi ready to go, so that when your patient eats through it like candy to keep their blood pressure up, you've got a couple syringes ready to go with it. The pitfall that I see a lot of times is people have one syringe ready to go and they're giving 10 or 20 mics every 2 minutes. You're through a syringe in 5 minutes, and that may be the time that it takes to get you back out to the rig. And now you're going, oh crap nuggets, now their blood pressure is back in the can and I don't have any meds ready to go. So kind of the thought with this is taking a few minutes to get all of this stuff set up. And quite candidly, if they're going to rearrest, most of the time, it's going to be in that first 10 minutes. And what we found is that in that first 10 minutes, if you're moving them, the rearrest gets missed, because understandably, everyone thinks that it's movement artifact, or people don't have a hand on the pulse because the patient's moving and maybe their legs bent so you can't actually feel their femoral pulse, or their neck's flopped over the place, whatever it is. There's a lot of things that can contribute to missing that rearrest. And the longer that's missed, you've already got this sick heart and sick brain that are getting poor perfusion for a longer period of time. So this is coming. So here's some cutting edge fun stuff, but this is one of the things that I would probably recommend for your post-ROS patients, taking a look at least considering for a couple minutes, so that you can optimize them to try to prevent rearrest. And quite candidly, if they do arrest again, in that first 10 minutes, then you have not delayed them getting treatment by, or potentially missing that they re-arrested, and that can potentially help with some of their management. The other thing that I will mention, because I've seen it I think I saw it one time when I was going through cases here and one time with one of my other departments, is the concept of pacing in an arrest patient. This is out of ACLS protocol as of several years ago, but it does still come up when to pace bradycardic patients, including the discussion does come up for arrest. It is no longer recommended to do transcutaneous pacing for patients that are in cardiac arrest. If they still have a pulse and it's severely bradycardic, but they do have one, that's where pacing is recommended by American Heart Association, and the ACLS, ALS algorithms, etc. Once they have no pulse, we no longer pace them. At that point, we are going towards standard ACLS management with compressions and then defibrillation per that protocol. So just want to make sure that we mention it for people. I would say that so that, say you have a patient who, and I bring this up, say you have a patient who's pericode. We can easily see this in someone who has an inferior STEMI, and we've been pacing them because their STEMI took out the pacemaker of their heart, and you're noticing you having to keep go up on your the electricity voltage that you're giving this patient. At some point you run out of electricity voltage, and now you're realizing you don't consistently feel a pulse. At that time, it's probably reasonable to consider managing this more as an arrest, so that you can make sure that you're still perfusing whatever coronary that they still have at that point. Because once you're not feeling a pulse with it, it's not doing its job.
So on this case, I was on this one,
Not addressed.
so this was the day we had the free cardiac arrest. We're on 2 of them, which I'm sure are in here.
Yes.
I'll let this go out and we'll. So on this cardiac arrest, the gentleman was at the top of the steps, so it's difficult. We have people staggered throughout the stairs, and on top of the landing. They had placed the IGL as they noted. We did have a discussion. I actually had gone to the head at one point, because they had requested me up there. We were having the determination of pulling the IGL and tubing him straight. The discussion on the scene was a GI bleed as well. This gentleman in hospital ended up getting 2 units of blood, because the hospital was on board with it too.
The reason to stop for
As a consideration though, of this being a GI bleed, guy had talking to the wife, had been complaining of abdominal pain, had been complaining of nausea, had been complaining of dizziness, like orthostatic drops, that kind of thing, where he stand up, and actually before he collapsed down at the top of the stairs, he was stumbling. So everything was painting the picture to no other medical history, no other thoughts of other, outside recreational drugs or things like that. Myself and Dr. Roche actually talked later in the day, or the next, I think it was later that day on this case, and compared notes and thoughts, and we were on the same page. But critical case, it was late in the arrest when we did feel the pulse. We did have an organized PEA, probably about 10 to 12 minutes into it, but we couldn't palpate a pulse.
Yep.
But the question was, is this guy that hypovolemic that we're not palpating that pulse? So that played into this. I had kicked you guys this through the app, told you to look at it after this arrest on the way to the hospital. And that's where it was captured for the pacing and all that. But no, it was a great case. The thing I do also want to highlight with this one is this came out as an unconscious.
Send 3, like they're back.
Okay, cool.
Sorry to interrupt, but they're.
No, perfect. But I do want to highlight that the crew did a phenomenal job taking the right equipment in. So when this did get upgraded to a non-breather, they had the appropriate resources there, and worked as a team.
Nice.
Again, this was Medic 75's first of what ended up being 3 cardiac arrests that day, and 2 of which were medical, and then the 1 traumatic, which I'm sure you got. So, but I just wanted to highlight those points.
No, thank you. Awesome.
I guess one other thought if you're calling it more symptomatic bradycardia rather than undifferentiated PEA arrest and going down kind of the external pacing, I guess you could have, I don't know if you guys considered atropine as well. I mean, I don't know that this is like due to like third degree heart block. It's probably more just like a pericode agonal PEA rhythm kind of thing, in which case they just need volume and blood and possibly epi kind of thing. But I guess you're kind of going down that pathway. You could also, I don't know if you guys considered atropine. I'm not saying that like we should have or could have. I'm kind of more just throwing it out for folks' thoughts of
Yeah, for
kind of
sure.
pacing if atropine would have been a consideration too.
Yeah, so, and I think it does play into it. So once they loaded the medic and started the hospital, they were still good at a pulse rate at that point. Once they started that transport is where it had dipped down. They already had the pads attached, so went to the pacing option early, which I like. Because a lot of times now we want to pull up, push those pressors if they're not pulled up, and really delaying fixing that problem when you already have the pads attached. So I don't recall, we did have a decent discussion after the case. But I don't recall if they had talked about atropine or not, but I think that was the justification of going straight to pacing. Was it was still a very organized rhythm, and they went with already having the pads attached.
Okay.
That's fair.
Yeah, and I totally fair, 100% agree. I think with that kind of decision making, I think it would have been fine to pull up atropine if it was going to take a while to set up the monitor, or maybe like two things at once kind of thing. But
Yeah.
I do not want, what I don't want to do is discourage external pacing for symptomatic bradycardia. I think that was kind of a neat decision making, because probably I'm not sure everyone would have done that and thought about that. So I'm really encouraged to see that, kind of it was quick to the pads and quick to external pacing for symptomatic bradycardia. So definitely want to highlight that. Yeah, interesting case.
Yeah.
Did it end up being a GI bleed? Did we do follow up with Lauren on that one, or should I take a look and see if I can find it here somewhere?
If I recall correctly, this guy ended up living 24 hours. This is a case that I have in my plethora of Rouse cases that we've been getting. This guy lived for greater than 24 hours and then expired the next day. Dr. Roche was in our discussion that the blood values ended up coming back okay. Now the question is, were those blood values delayed in dropping, and they're still showing okay even though they weren't yet? And then, but he had given the 2 units of blood as well, as kind of a prophylactic of what we all believed was the case of a GI bleed causing this guy to code. The wife had tried to get him to go to the hospital the night before, didn't want to go, and should have. So, good talk.
Yeah, this was one. I apologize, Richards. I didn't get a chance to forward these to Lauren yet, just with the week, but cool. Thank you. These two, if we have time, we will come back to these. This was actually, these two I wanted to spend a couple minutes on. So these are 2 seizure cases, which is what I picked them for. So this first one, it's a 9-year-old female. There was a call for a patient having a seizure. Patient had a known seizure disorder, but hadn't had a seizure in several months. Family called all of us there, and I think she was still having her absent seizure pathology, which with those, as opposed to having that tonic-clonic, it looks like they're just staring off into space. Absent seizures are a little odd, as those tend to have a very strict type of anti-epileptic medications that will actually treat them. So as opposed to having all the jerking with it, they kind of just look like they've zoned out for about 30 seconds and they come back. But in this one, talking to mom, it sounded like this was her typical seizure morphology. And they'd already given her rescue med without having any improvement with it. She still looked like she was out of it for our crew when they got there. And they ended up giving her 6.8 milligrams of Versed, IM to the patient to help treat the seizure. And it sounded, I believe, like she actually improved after getting that and went to Children's Liberty and did completely fine. The second case that I had was a pretty standard seizure case where it's a 69-year-old male with a history with seizures. Gentleman was found seated on the bed when he started having these convulsions that look like your standard tonic-clonic seizure and has a slightly decreased GCS. One was found by a crew with GCS of 14. Gentleman is originally not from the United States, so there's a potential that he may have not been able to get his medications due to coming into the United States. He ended up getting 10 milligrams of, I believe it was 10 milligrams of Versed for his seizure activity and ended up doing 10 milligrams of Versed that went in IV and his seizure activity stopped, taken to the hospital, etc., and did completely fine with that. So this is one of the things I actually gone over with McMullen a little bit, and it's the seizure medicine, which comes back to the whole Rampart trial, which was several years ago. What are you laughing at?
I didn't see it.
I know, I'm sorry. I'm sorry. I could have made it bigger. Is that better? No, it sounds like my computer. Sorry.
No, that went.
Did it actually work?
Yeah, that did.
Oh my gosh, it did. Yay.
Right.
So as part of Rampart, which was one of the studies looking at IM versus IV benzodiazepine, they looked at Ativan versus Versed head to head, and really showed that there was no difference between the two in regards to like how quickly they aborted seizures, which is why in the emergency department you will see a lot of times people grab like 2 milligrams of Ativan and give it to patients because we already got the IVs established and just grab the Ativan and you're good to go. In the pre-hospital setting, they did find some benefit to giving 10 milligrams of Versed IM due to not having to have an IV established and a couple big muscle targets that you can get it into on patients when they're actively thrashing all over the place, and it being equally efficacious, as well as some thought that it may have a little bit better in the formulation, better penetration to the brain. The study for Rampart, though, looked specifically, when you're looking at kids, they cut it off by the kid's weight. So in adults, what they found was 10 milligrams of IM Versed worked for aborting seizures just as well as doing it with the IV Ativan. And given the logistical improvement by doing Versed in the field as well as Versed not needing to be refrigerated, let's go with IM Versed. And that's why we do most of that now. In the peds world, though, when you look at their study population, they sussed them out by weight. So kids that are 40 kilograms or greater, they get treated like adults with 10 milligrams of IM Versed. If they're 13 to 40 kilograms, they got 5 milligrams of IM Versed. And if you're less than 13 kilograms, they were not included in Rampart. There is a study going on right now across the country called PD Dose, where they are looking at different types, different dosings of Versed to find out what is the appropriate dose for these smaller nuggets, the ones that are less than 13 kilograms. And that's kind of what goes into Southwest Ohio's protocols dosing algorithm for these kids. I think the dose that our child received, she was 9, she probably would fall into that 13 to 40 kilogram, maybe a little bit, maybe even like closer to that adult range. I think her dose is fine, the one that she got in the 6.9 milligrams, and I think that was probably based on her ideal body weight, based on the way that it was documented. But I did want to make sure that we talked about this for these younger kids, is that in the children that are less than 13 kilograms, it is unfortunately a weight-based dosing for those kids, but with a max dose that you're going to be going up to for that intranasal or intramuscular one of 2.4 milligrams. This is listed in Southwest Ohio Protocol's seizure one for the P, if you go in the PED sections listed in seizures, to have this chart available. I am also a big pimper of PD-Stat for pulling it up based on age or weight of your child to help have it do the calculation for you so you don't have to remember in real time. But in adults and children that are greater than 40 kilograms, we're going to do 10 milligrams of IM Versed. And that's kind of the logic behind why those doses were picked for people. Richards, do you have any other info on those, as you probably have way more involvement or familiarity with Rampart than I do?
No, I mean there's a temptation to certainly underdose benzodiazepines in seizure. So kind of adhering to, kind of Rampart and all the rest and being well justified in that. Will serve you well, just following the protocol. And then yeah, it'll be interesting to kind of see kind of a simplified dosing through that study that you mentioned, the one that's going on right now. So no, don't have much to add.
Yeah.
So the one thing I will add is, for our crews, remember, if utilizing PD stat, there is one spot that we have highlighted is this exact thing, and that's Versed for peds, where it doesn't directly match the protocol. I've actively been looking at a program called Hand Tevi, and my hope is to push for us to get that program next year, which will take the protocol and put in an app form plus a lot of the other beneficial features for our crews, that's tied directly to the protocol, so that the app of Hand Tevi would be directly tied to the protocol. There's a lot more functionality pieces, such as being able to directly upload to your PCR what you did based off that Hand Tevi app for better accuracy and better just support for our crews in the field of systems that make our life a lot easier and a lot better, thus providing better patient care, more accurate, correct dosed patient care. So there's a lot of benefits to it, something I've actively been looking at, getting quotes and all that stuff. And myself and the EMS committee, we will push through a few more steps, but my goal is to get that for next year. So more to come on that process.
Nice. And I did want to highlight what Dr. Richards said too, underdosing. So there is a huge, as he said, there's a huge temptation. And it's not just EMS. I see this with my residents and sometimes my colleagues as well, where people want to underdose the benzodiazepine for seizure patients. What we find is that when that happens, they don't actually stop the seizure. So they have a much higher likelihood of remaining in status or having their seizure go incompletely treated. So that's part of the reason that these doses were trying to be set very specifically for people. With any benzodiazepine dose, there's always a risk that we're gonna have to take the airway, which we're pulling up Versed. I wouldn't anticipate having rode with the crews that is what everyone is thinking about anyway. But just as we want to make sure that we don't completely respiratory depress them, there is as great a concern, potentially even a little bit more, that if we don't treat their seizure, their brain is going to continue to have this electrical storm in it. So please the protocols have been put in place that back up this decision making. Rampart backs it up for the doses for people to dose them at the 5 or 10 milligrams of Versed. I've not run into it here, but I do just want to reinforce it for people. Yes, this was our case. So next two that I had the pleasure of actually being on the cases, I believe. Yep, this was it. So I had the pleasure of being on these two cases. And the first one was a cardiac arrest for a patient who was at one of the local nursing homes. I'm blanking on which one. I want to say it was the Chesterwood, thank you. 72-year-old female found down, unknown amount of time. And by the time I got there, our crews already had eye gel in place, had IO access on her. She had been on Lucas. We're doing epi. And I think ended up while we were there, got IV access on her as well. And the whole time she remained in asystole. We went through and emptied the drug bag with all of the epi for this patient. And then one of the things that we talked about is we actually ended up giving her calcium and bicarb, and that was per my call. So that kind of course, this patient was in asystole when we got there, and unfortunately remained so throughout the duration of the code and ultimately expired. But it did prompt me to take a little bit of a look at some of these adjuncts we have, this calcium and bicarb, because for my own personal practice pattern, I have found that some of my patients that are in a non-shockable cardiac arrest, primarily PEA, that in those, if your concern is that it is severe acidosis that leads them to have this, led them to have an arrest, I have found some potential benefit with bicarb. The other big one being patients who may have severe hyperkalemia. So this will be a patient who has been down for a long time and has severe rhabdo, patient who is a dialysis player. In those situations, have seen some patients have a little bit higher levels of ROS, but wanted to take a look and see if there was any literature on the uses of these two adjuncts, because our Southwest Ohio protocol says you may consider using them, usually later in the code. So the first topic that comes up with that is, do these actually help? For the literature that I found with my kind of brief perusal, I did find this meta-analysis, I'm sorry, the top of it is cut off, but this looked at the CPR papers published from like 1962 until 2 years ago, where they looked at the potential implications of using sodium bicarb for patients. And the conclusion that they came to was that looking over the data, it did not necessarily improve survival for patients, except for the ones that I delineated on the side. So patients with a TCA overdose, patients who had severe hyperkalemia, say your dialysis patient, your rhabdo patient, etc., or patients with severe cardiac toxicity. And I did not get a chance to delineate exactly what that was, but for patients that say just had like a severe respiratory acidosis leading them to have their arrest, so your COPD or who can't blow off all their O2 or their CO2, or your opiate overdose that has a bunch of CO2 retention, didn't necessarily show that it significantly helped them, and probably the focus would be at that point on excellent airway management and ventilatory management for those patients. On the calcium side, the one that I found the most benefit for was again the patients with hyperkalemia, or the ones where you needed to stabilize the cardiac membrane. I think those would be the cases where if you have concern for one of these, and I think the potassium is going to be one of the most common ones that we would run into with all of our dialysis patients. These are ones to consider doing the sodium bicarb or the calcium on. I am still working on my own personal practice pattern, but I have a really low threshold to grab either of these on a non-shockable rhythm. The other thing that I do want to bring up though is that what we know from cardiac arrest data is that if anything is going to actually bring these patients back, the interventions need to be done very promptly or very early in their arrest. So I am personally in the camp that if you're going to do calcium and bicarb, if you're considering it, give it early in your first couple doses of epi. Because if you wait, we know that after about the 10-minute mark of arrest, your likelihood of getting them back at all starts to drastically drop off, particularly with them coming back with retained neurologic function. So that's one issue that I have had kind of looking at the protocols, is that if you are going to consider these medications, it's worth considering doing them earlier so that they can actually have an effect before all of these cells continue to die and we're just giving medications to someone that the likelihood of them coming back is very low. So those are kind of the things that I looked at after seeing this case. But Richards, I'd be curious to see your thoughts on these non-shockable rhythms as well.
No, I agree. I mean, there definitely is a difference between like the undifferentiated arrest versus walking into something and you have a high suspicion for something and you can just targeted therapy. So I totally agree with gathering some history from bystanders, medical records, looking at the patient. I mean, if you big, HD fistula or something like that, if you're able to gather some information, target some therapy based on that. But otherwise, yeah, totally agree.
All right, and then the second case that I had the pleasure of being on was, this is the third one from that same day with all of the arrests. Everyone died in Westchester that day. This was a one with 75s where we got dispatched for a GSW, and having been on the call, can attest that the Dispatch story was slightly different from what we got on scene, which does happen. It's just part of trying to figure things out when people get there. But the story was for a young gentleman who had presumably a GSW to somewhere on the body. We initially and then later found out it was the head. To get to the patient, we had to go through a cement wall, one of the ones on the side of the highway, where there was like a 3x3 cutout for us to crawl through and pass the equipment through. And behind that was a little creek with a little yeah, this one with a little like a little drainage bridge over top that this young patient had presumably shot himself in the head. When we got there, there was some debate between the dispatch discussion that the GSW had happened very acutely versus no, we think this has happened for quite a while ago now. And by the time we saw the gentleman, he had a clear GSW through both temples with some exposed vein matter, and he was slightly cold. But what I commend the young paramedic for on this one is that he came in and looked and was looking for the signs that would indicate non-initiation. Those are things like lividity, rigor, or decomp. This is one of the things that I will admit I feel kind of strongly about, but you will find different opinions on going through different EMS pre-hospital providers and medical directors. Our Southwest Ohio protocol says that unless you see those very clear signs of patients being not resuscitatable, something completely incompatible with life, they're actively decomposing, that those are patients that we do not start resuscitation on. An isolated GSW is specifically pulled out in our regional protocol as not a indication to not start therapy for these patients. So the paramedic that I was with, he actually did a really good job because we crawled in there and he said, like, I don't see either of these. So he and I started doing the traumatic arrest algorithm on him. The gentleman, of course, as we would expect, was not resuscitatable, but I do think in some of these cases that there's a couple of things to bear in mind. Isolated GSW is not necessarily incompatible in life. It depends on what it traverses through. And even neurosurgeons, when you talk to them, will say that they want to see potentially a head CT to really determine it if you have like some type of life that comes back for patients. The other thing to consider for some of these patients is that the ambient temperature, this patient being in, cold spring water, kind of running through, like actively running cold water, is going to artificially lower the body temperature. So body temp isn't always the best thing to rely on for a patient to help determine how long they've been down. And some of the stuff that I looked at a couple of months ago when I was looking at the discussion of, or kind of definition of lividity and rigor, specifically call out things such as dewdrops, cold running water to very quickly artificially lower a body temperature for even a patient who is alive. So I will see this intermittently, not necessarily with our DOA documentation. The ones I've seen, including this month, we do a good job documenting clear decomp, clear lividity, clear rigor, but I do sometimes see people using that the patient is cold in an outdoor environment as a reason that they think this patient's been dead for a long time. And I would caution against that, as that is a level of education and calculation that even I as an ER doc don't have. I would actually refer to a pathology colleague or someone from the medical examiner office to really clearly set that up. So those are kind of two things on these isolated GSWs to the head. And I do give the crew on this one, they did a really good job climbing through a stinking hole in the wall and managing a traumatic arrest on a patient that we like quickly pulled out of water, and putting up with me saying that we needed to continue on, like at least for a few minutes of these. A few minutes of resuscitation on this one. And they did a really good job managing that and managing the situation with police as well, helping them understand why we're doing the things that we were doing.
Will you cover the reason we decompressed?
So this is one of the areas that, depending, from my understanding from national conferences, you will find different opinions on this. In our region, the discussion that has come up from Southwest Ohio protocol meetings, from my discussion with like Calhoun and a couple others, is that the thought process is twofold. Number one is that we may become fixated on the obvious GSW to the head and may miss a secondary site that could lead to a pneumothorax. It happens in ERs as well, where we will miss people's other injuries until they're completely stripped naked and can see everything. Because everyone focuses on the obvious injury to the head. So it's still possible to miss another injury somewhere on the body that can lead to a pneumothorax. And if this is not the thing that is killing them, the head wound, but this is actually the thing that's killing them, the second injury that's causing a pneumothorax, it would be a shame to miss something that could reverse that, particularly because we do know some patients that live after GSWs to the head with sometimes even good outcomes as well. And it's not meant as a understatement of people's skills. I even just chatted with a resident last night about a patient that she had where due to copious skin fold, they missed a penetrating neck injury. You think that would be obvious, but it's human. It's a human thing that it happens to us where we become focused on the obvious injury. So this is kind of put in place to help protect us and make sure that we're treating all of these equally and helping protect us from anchoring on this obvious head wound. From the other standpoint, it does also make sure that we treat all of our traumatic arrests the same with all the same procedures so that we're giving everyone a fair shot as well. Now, I will tell you, I have read through some of the literature on how many of these GSW to the heads actually come back, and it's abysmal. But the ones that do come back, there is a huge variance in their ability to come back normal versus not. And for the 10 minutes of resuscitation effort that we do for an arrest, because it's considerably less for traumatic versus medical, it's probably still worth it to put it in airway, do decompressions, give them a fluid bolus, and see what we have from there. So that's my thoughts on that. Richard, so anything to add?
No, I agree.
I have a question.
Yeah, please.
So, are you considering a gunshot wound to the head as isolated penetrating trauma, or what protocol actually specifically states?
Sorry, say that again. I had the radio go over your last sentence.
So, are you considering a gunshot wound to the head as isolated penetrating trauma?
Yes.
Okay.
Yeah. And I forget exactly how Southwest Ohio protocol words it, but I do think they mention it as isolated. It's either they say isolated GSW to the head or isolated penetrating trauma, but if memory serves, it does pull that out as an example of something.
The latter, they don't define it as a gunshot wound.
Okay. Yeah, I think having talked to, I think from my discussion with Calhoun on this earlier in the year, is that was one of the situations they were referring to, is that isolated GSW to the head. They just call it isolated penetrating trauma, so that, I don't know, if someone gets a crossbow injury to the head, that it's not excluded. Could happen. We're in Ohio.
Axe throwing is.
Axe throwing, something of that variety.
Good question.
Yeah, thank you for that. Which one is this one? Oh, this one. So next case that I've got, this was one that I wanted to bring up for discussion, because I will put forth my own thought processes on these types of patients, having been a magnet for this type of patient, and will happily take input from Richards and Whitty as well. So this was a challenging case, teenager who attempted suicide. And this patient took a ton of medications that can be fatal, particularly patient took a bunch of Adderall and a bunch of iron, and iron can be a very dangerous toxidrome for patients. This patient also, unfortunately, was not willing to cooperate with our crew, with police officers, etc., and was unfortunately very combative. The crew documented trying to do a lot of verbal de-escalation with the patient, and unfortunately that was unsuccessful, as it often is. So they had to take the patient unwillingly to the hospital. PD attempted to help by restraining the patient to the stair chair. And I believe that they actually ended up trying to use their handcuffs to help facilitate this, to get her to the hospital. She broke out of those, and then started thrashing around, becoming very combative with people, ultimately needing IM Versed to help facilitate just getting her into the ambulance and getting her to the hospital. And there's a lot of discussion that any further resuscitation was quite challenging due to how combative the patient was. So this, if you ask any of the nurses at UC, I am a magnet for the excited patient, the like hyperexcitatory state patient, severe agitation, to the point that as a 3, I had a couple attendings that said, you're gonna just start with 10 of Versed and 5 of Haldol. I'm like, yep, because this is my 3rd meth overdose I've seen this week in the cocktail works. So I will preface this with that I am personally fairly comfortable with giving these patients medication because of my own practice pattern, which is they get Versed, we get them down, and then they are immediately on all of the monitors, and I sit there helping hold arms, legs, whatever with my nurses, because I think that's only fair, and try to do the same thing when I'm out with people in the pre-hospital setting. We do know, and this is a hot topic as well in EMS between discussions of ketamine and discussions of managing patients in this hyperexcitatory state. We try not to use the term excited delirium anymore due to some of the racial implications with it, which is why I'm trying to pick phrases such as patients in severe agitation or hyperexcitatory state. So in these patients, particularly patients where they're being involuntarily transported to a medical facility, so they have a pink slip on board with them, where they have lost their ability to consent to medical care. As we've all seen, these patients will oftentimes become very combative and frustrated on top of their already present excitatory state, say from an intoxicant or from them being agitated, having some psychological distress or psychological decompensation. The problem with that is on top of, in this hyperexcitatory state, you have a bunch of body systems that then go into overdrive. These patients can get profoundly acidotic, which once they crash, that can then lead them to have potential setup for a full-blown cardiac arrest. They have massive lactic acid buildup, and they have a bunch of muscle breakdown leading to rhabdomyolysis, where they spit a bunch of potassium into their blood, a bunch of myoglobin. And sometimes these patients, say patients who are in this excitatory state from a sympathomimetic overdose, so your meth, your cocaine, intoxicated patients, I have seen some where they then become restrained in their bed and they thrash against the restraints for hours and hours and hours, insufficiently sedated, and they send themselves into kidney failure from continuing to break their muscles down. So it is a very dangerous state, both for the patient and for us as the providers when we have patients in this agitated, excited state. So if you're going to bring restraints into the equation, which is going to make this worse. No one, except for a couple people that we will not talk about right now because I'm being recorded, likes to be restrained. Most people, when they have that happen, are going to become very frustrated and even more excited and want to get out. So my argument is that if that is the case, probably the right thing to do is if you're going to consider doing a physical restraint, I would look at very quickly going to adding some type of chemical restraint on board to help get them to tolerate the restraints. It also helps keep us safe and helps us aid in the assessment, because the most dangerous thing for a patient is when they have meds on board and we cannot adequately monitor the response to the meds, because they can compensate for a little bit and then they can potentially crash, and when they crash, it's really bad. So in these types of patients, I like that this crew went to get Versed. I would argue if you're going to start trying to have to do physical restraints, try to have that chemical restraint ready to go with it. So you don't have to worry as much about patient getting out. And as a reminder, Versed takes about 10 minutes to kick in. So the sooner that can potentially get on board to help these patients tolerate the situation that they're in, and then the sooner we can get monitors on, the better all around. Ketamine brings a whole nother thing into this equation, complete with some of the political discussion that goes around it right now. My thoughts on ketamine for chemical restraint is I am pro it if you make sure that you're doing it like dosed based on their ideal body weight, and you start your monitoring right away. And whenever you're grabbing one of these medications, you are ready to manage an airway. That's what we do in the hospital. That's what I think we need to do in the field to help make sure that they stay safe and we stay safe, so no one gets punched and kicked down a flight of stairs as well. Roast fun. Other thoughts, Richards?
I don't. I 100% agree. I'll just echo a couple things you said. If you're doing physical restraints, um, really kind of having the chemical um, medications out and available, and really with the expectation that that's kind of your next step, is really the approach that it should be. And then I'll also just highlight, a lot of kind of attention is being placed on runs like this, right? And rightfully so. And so being aware of the protocol, us reviewing it, being aware of positions that absolutely the patient cannot find themselves in, like prone, hogtied, these kind of things, and really knowing where your benzos plus or minus ketamine are going to be important for these situations. It's good to oftentimes review really kind of the letter of these policies, of these protocols, with some regularity. So I'm glad we're looking at this case.
The only other things that, because I looked at it this morning while I was going through, it says don't transport patients prone, mostly because that has happened and that has led to patient deaths. So that's why that comes up. And that included, I actually saw a case at NAEMSP where they showed us the body cam footage, and the patient, like, their heads turned this way and they've got some type of bolster kind of underneath their chest. So it's not that their airway is impeded. That's not the problem. It's the chest rise being impeded with the prone position that ends up being a problem for these patients. So I think if I was just looking at it as like from an airway standpoint, no, this guy's head is thrashing all over the place with no impediment to his mouth or his airway. But the torso and their ability to do chest rise and fall, that's where you run into problem with the prone positioning for patients in this state, especially once all the meds get on board and then they drop. You have now got the weight of their whole back that's on their chest, and they're not going to be able to rise and fall as effectively. And then the other thing, because PD used their handcuffs, that's okay per Southwest Ohio protocol, that's fine. As long as they're there to undo the handcuffs, and they go with the patient. So that is completely fine. I want to make sure that is clear, that it is okay for PD to bring them in handcuffs or have the handcuffs on the cot unconscious. As long as we have a way to get them out.
Two things after this dispatch.
Seven one three three Demick Road, cross streets of Crestfield Drive and Friar Tuck Drive, TSC 210 and 1414.
First thing, our protocol states that we can't restrain people with handcuffs to equipment. And then second, ideal body weight is mentioned for a couple things in the protocol, but I've never had a training or have anybody ever explain how we calculate that to really make that usable in the field. So that's the question there for, like, if we're gonna do ketamine as ideal body weight base for restraint and whatnot, like.
Yep.
How are we doing that if there's no way for me to actually calculate it?
So my understanding is that they were going to be coming out with the ideal body weight chart. So it's secondary to height. I'm 1000% back you saying that people don't know ideal body weight.
No.
And there's lots of things in medicine that are induced or devices that are used, such as the eye gel off of ideal body weight for sizing purposes, just because they're 500 pounds and 5'2", their airway size doesn't change. So yeah, no, it's a very valid point. What we can do before I had promoted, I was creating a list that I was going to get the pharmacist at the hospital to approve. But then at that point, I was told that it was coming in the protocol anyway, and we have yet to see that. So what I can do, DZ, is find that list that I had before, and then I can kick it through medical direction and kick it through pharmacy. And then that way we have a good educated resource that we can utilize in our units.
Yeah, cause I'll give you the pain management. And I mean, there is a chart for it that's based on height. But
Right.
the protocol gives us 3 different ways to decide how to calculate that dose.
Richard, do you know if that's coming up with Southwest Ohio tomorrow? I don't remember if that's on the docket for tomorrow.
You know, I have not looked at the agenda for tomorrow. My understanding is the same as what you guys are saying, which is essentially be a height based guidance document that might just be a rider to this one, to the pain one, but it may have actually already gone through and tentatively approved. But I'd have to look at the agenda to know for sure.
Because ideal body weight, all it is it's based on height. We'll double check on that. We will let you guys know.
Yeah.
If I don't, Richards will.
Yeah.
Sorry. The other thing that you can look up, let me see, I think my camera's on. Yep. So you can look up, which is what I will use in a pinch. There is, if you do MD Calc ideal body weight, that does pull up a calculator that you just throw their sex and their height into. So like this is mine, where female who's 61 inches tall, because I'm short, and that would give my ideal body weight. I think this one is in pounds. I think I could change it to kilograms. So it's not, yes, it does have my kilos on the bottom, which would be 48. Oh my God, I need to lose weight. Anyway, but that is an option that you can use until we get this sorted out, but we will take a look at that.
What was that again?
So it's called MD Calc, which you can Google. It's free, all access, which is what I like about it. I think they have an app that's free you can put on your phone too, but you can just Google it. And I think I literally just put in MD Calc ideal body weight, and it pulls it up that you throw their sex and then their height into, and it will pull up their ideal body weight based off of that, because it's all height based as their measurement for it.
And I think to speak back to that hand heavy product, I believe there's access within that to do the same thing, which would add another benefit to this.
What about the light packs? Didn't we talk about those to be programmed?
You
per
can't,
Protocol as well?
not yet.
Not yet.
No, they were working through, Stryker, I just got an email this morning. There's some updates coming to the LifeNet system. There's some listed, but I haven't seen the functionality of what all of those are yet. But they were trying to get certain parts more user specific, where we could add in,
Our
Our stuff.
protocol, so the guys go on a seizure,
yeah,
or they go on a restraint, they pull that protocol in the light pack already.
correct. Where with hand heavy, they would have that accessibility, plus when they lug it, they could upload that to PCR under ESO, just like the monitor data will upload under ESO.
Okay.
Yep. Good questions.
No, thanks. Great discussion points. Forrest coming in with good questions.
Daisy, did you have anything else, or did that answer your questions?
No, it was just, the other one was just that realistically, the protocol does say not to let handcuffs be placed on.
I just read it.
Yeah,
And ironically, we can tie them to the cop, and the cops hand
Right.
cannot.
between soft restraints and hard restraints.
Yeah.
Oh my God, fun times.
Well, I guess that's if they had if you had an accident or something.
True.
Able to get them off of it quickly.
Yeah. Yeah. Make fun. All right. Okay, so then this was, I think this will be our last one. It'll be just a quick reminder. So this was a 54-year-old gentleman complaining of chest pain who made the decision to take some marijuana gummies and a bunch of cigarettes, and shocker, his heart didn't like that plan too much. Gentleman was complaining of significant chest pain. His remaining exams overall really not that exciting, but he does have a 12 lead with a inferior STEMI with true reciprocal depressions documented for it. Noted significant pain with it, and the classic pain where it's like left shoulder going down the arm, etc. Crew did almost everything right on this one. Got the patient like on the cot, sent it to the hospital, did STEMI pre-notification, got IV access, gave him fentanyl. There's one thing that we didn't have on this one, and it was aspirin. I went back through looking, so it's at least not documented that the gentleman received or had taken very close to arrival to EMS arrival the full dose of aspirin. So this is one thing I just wanted to give a reminder to everybody that aspirin and STEMI is one of the like few recommendations that we have data behind that shows it actually significantly can improve patient outcomes, patient mortality, morbidity, etc. And has a very low number needed to treat, meaning that if you give so many patients this medication, you'll have one person that has a improvement in their outcome because they got the medication. Some of the ones I saw was as low as like 1 in 7. And we don't see numbers like that very often in medical literature. So this is one of the things that, and the sooner that these patients get their aspirin, the better they potentially have for outcomes. This can end up reducing like some of that platelet aggregation for them in that acute STEMI phase. And there's some data that shows that it helps lessen the likelihood of patients having major cardiac events afterwards. So things such as complications from their calf, worsening, like potential reocclusion, etc. I did interestingly look, and there is some discussion right now in the literature about potentially decreasing the dose of aspirin that patients would be getting. Instead of getting that 325, giving like 162 of it, so half of it, because the biggest concern that people have with aspirin is it's going to make them bleed. So one of the papers I looked at recently was looking at giving the typical 325 versus 162. And there was some indication in it that they might have the same efficacy with less bleeding results with it. But they're gonna have to do a lot more. They're gonna have to have so many more people involved in that study to like get enough data to say that it is equally as safe as the full dose aspirin. There is one contraindication to giving aspirin for patients with STEMI, and it is if they have anaphylaxis to aspirin. Otherwise, that is one of the things that we do need to make sure that they get, and the sooner they get it, the better. That's why most of the time, like if you bring a patient with chest pain to the hospital and they got aspirin, like most ER docs, if they're being appropriate, are not going to quip over a patient with chest pain having got aspirin, because the risk of them not getting it is far outweighed by the potential benefit of them getting it far outweighs the potential risk of them getting it and not actually having a cardiac event. So this is my one gentle reminder, please give aspirin. And for sake of time, I think we'll wrap it up there. The other two cases I had was just Narcan and a patient who had some airway fun stuff, but nothing crazy.
Can I make one caveat to the whole aspirin and chest pain thing?
Yes.
So for the group, listen to exactly what Dr. Hillison said in terms of chest pain and aspirin, 100%. If for some reason though, you get a story that's very, very consistent with like aortic dissection, or like a sudden onset tearing pain in the chest that goes to their back kind of thing, because you can actually get aortic dissection, disrupt the aortic arch, and it can actually dissect back into, and actually usually if it's going to happen, it's going to be the RCA, so you're going to have an inferior STEMI pattern from a dissection. And so for some reason you have like a high suspicion from history, you either just would want to hold off on the aspirin, or if you want to have a conversation with med control in that situation and say like, hey, this is how they described it: sudden onset burning, going to the back, their pressures are soft. It's chest pain. Do you want me to give aspirin, or just wait until you guys see him and you guys can do it there if it turns out to be a STEMI? That kind of conversation is very reasonable. But on the balance, though, 100% agree. Just with that one slight caveat is all. Go.
Anybody else from the companies have any questions for Dr. Tillotson or Dr. Richards?
Yeah, I got one more about the aspirin. I haven't done it, but I know it's a decently common practice that if patient has had aspirin already that day, that the dose gets reduced. Is there any efficacy to that at all?
I actually don't know for sure. I don't know, Richards, do you know on that one?
What I would do is if they take a baby aspirin in the morning and call in the afternoon, I would like top them off. So like
Yeah.
325. If they've taken a full dose that day, I would skip it.
Got it. Thank you.
Good question, Steezy, thanks.
Yeah.
So that being all completed, Kelly, thanks a ton.
Thank you guys.
I really appreciate it. We appreciate you. You've been